Hello, I'm Cindy from America's Best. I'm the respiratory therapist, and we're going to go over nebulizer machines, documentation, and then O2 delivery devices. Each little packet that you have has a pre and a post test, so I need you to put your name and today's date and do the little pre-test, and it's true, false. Now I'm going to go over oxygen delivery devices. Up here in the top is a handy little box. Just tells you that room air is 21%, 1 liter of oxygen is approximately 24, 2 liters is approximately 28. They go in about a 4% increment. So sometimes you may get a CPAP or a BiPAP order. It may have the settings and then have FiO2 of maybe 40%. So your little cheat sheet there, you can figure out that you need to have it on 5 liters. Then we have the nasal cannula. We do these 0.5 to 6 liters. We used to always humidify it, but now they say below 4 liters you do not have to. It just depends on the resident and the facility, you know, if you're going to use humidification. We actually now make the nasal cannulas that they're soft, that you don't have to use the ear wraps anymore. So it's a lot easier on the patients, on their ears and their face. Then if you have somebody that won't keep the prongs in their nose, the nasal cannula, they have what is called a biflow mask. Cute, aren't I? This you can do 0.5 to 6 liters. You can also use humidification. They also make that real soft too, so you can maybe tolerate that. Then the one that gets kind of messed up quite a bit is your simple O2 mask. Minimum flow on that is 5 liters. You do not want less than that because they'll rebreathe that CO2 and then they'll start getting more lethargic and you don't have to worry about them fighting, you know, having a mask on. I do have a type of mask that I think benefits a lot better, so I will show you here in a couple of minutes. Then your Venturi Mask. This mask is the only mask that actually puts out a proper percentage of oxygen, doesn't depend on technique. Down at the bottom, it'll tell you what flow to run, liter flow, and it'll tell you what percentage. So it takes the flow of oxygen plus room air and trains it to give them the percentage. There are 2 different kinds. There's one that's a low flow that you can run on 3 to 6 liters, and it will dial in 24 to 50%, or else this high flow. It'll have each little colored dial will tell you what liter flow and what percentage of oxygen. Then your non-rebreather, minimum flow on that is 10 liters. You do not want less than that. You want to make sure that bag's inflated. When they inhale, it can collapse somewhat, but if it completely collapses, you'll want to increase the flow. This we normally use when somebody's crashing. You know, get the E cylinder, crank the O2 up, and try to get their sats up, and then possibly have to send them out to the hospital. Then this is the mask I was telling you about that works a lot better than the simple O2 mask, and it doesn't really have to worry about them breathing the CO2. This is called an Oxy Mask, and it has all these little openings here, so somebody that is got COPD, they're kind of claustrophobic, they will not fight you as much, and if they need a drink, there's a little opening there that they can put their straw. The opening is right here, so it basically hits the nose and the mouth. So this you can do 1 to 15 liters. Then the last one is our little Oxidizers. Somebody that's been on a real high flow of oxygen, they may use something like this. So say somebody that's normally been on maybe 10 liters of oxygen, you can bump them down to about 7.5 with this. The reservoir's there, so they're breathing 100% oxygen. The only thing on these, they get changed monthly, so I would put on my Mars that I'm cleaning them weekly with sudsy water, so the state will know that you're doing things properly. If there's no further questions, we'll go into the aerosolized medication therapy, and that's where we're going to get the medication into the lungs, and we can go 2 ways. We can do the MDIs, the meter-dosed inhalers, or else nebulizer treatments. Purpose of that is to help open the airways, help improve the lungs, so maybe they can cough and get the secretions out. Indications would be somebody with like COPD, emphysema, asthma, to name a few. We have two different type receptors that affect the opening of the airway. The first one's a beta. So like I said, what it does, it goes and opens those airways up so maybe they can get those secretions out. Those would be like your albuterol, your Proventil, your Ventolin, your long-acting with less side effects, Xopenex. Sometimes we don't see that in the homes as often because Medicaid doesn't like to pay for that. Your second receptor after these airways are open, this helps keep them from constricting back shut, and that would be like your ipratropium bromide or your Atrovent. So that's why we see a lot of COPDers with albuterol and Atrovent. We used to see a lot of Duoneb, a lot of Comivent, but there again, Medicaid doesn't like to pay for it, so a lot of times you're seeing mixing the two. Inhalers, are they as good as nebulizers? Realistically, no. They say an MDI, a patient gets about 30% of an inhaler. A lot of these residents have never been taught the proper way to do it. You come in and you're trying to teach them the right way, and they look at you like you have four heads, and they tell you, give it here, I know how to do it, and they do their little puff puff and they're on their way. Advantages of a nebulizer treatment: it delivers a higher dose of medication to the patient, and it doesn't depend on technique. Those aerosol masks work wonderful. You can just put that on them and they can sit there and sleep or watch TV or do whatever. Then we go into abnormal or adventitious breath sounds. Try to narrow them down to like crackles or rails. Moist, they're moist. Fine is kind of like cracking of sand on a tile floor. You're getting me and I'm forgetting. Pardon me. And the excuse me. And the more coarse, they're kind of like intermittent popping and bubble wrap, and a lot of times it's in the larger airways. And if they get coughing, sometimes they can kind of clear up. Wheezes, everybody's heard of wheeze, nobody can mistake that. The two that you don't hear of as often, the first one is stridor, which is in the upper airway. You can hear it when you come in the room. It's due to inflammation in the upper airway or possibly cancer, tumor, something like that. And the other one is the pleural friction rub, and that's where the two linings in the lung are inflamed and rubbing together and sounds like creaky shoe leather and is very painful to the patient. The next sheet has techniques for MDIs. What I tell everybody, if you're in your window for state, review it. Just make sure that you wait at least a minute in between inhalations of the same medication and at least 5 minutes in between different medications. They have been known to time people, so make sure that you wait the proper amount of time. It's also a good habit to get into to either have them take a drink of water or rinse out their mouth after an inhaler, because sometimes albuterol will make their mouth sore. If you're doing a bronchodilator and a steroid, always do the bronchodilator first, get those airways open, and then come back through with your steroid. This sheet here just shows nebulizer treatments or nebulizer machines and how to possibly do a breathing treatment. You guys should know how to do that by now. If you run into a situation where you don't have enough nebulizer machines, you have your e-cylinders on the back of the wheelchairs or on the cart. Sometimes you can just hook up that tubing that you would normally hook to your pulmoid and just turn it on 5 or 6 liters, and it will nebulize the treatment until you can get enough nebulizer machines. Then on cleaning instructions on your neb cup, when you are done with the medication, dump it out. Rinse the cup out, dump it out, let it dry on a paper towel, and then put it in a Ziploc bag. If they find any residual in there and they ask you and you tell them it's albuterol, they can get you for med air. So it's best to have everything dumped out and out of sight. Then there is a section on medications for COPDers. The brand names, the generic names, and possible side effects. So this is just a little FYI for you to keep. And then at the very end, we have our post test. So you guys can go ahead and take your post test, and then she can go over it with you, and you'll be done. Thank you.